give me a hand here. Of course, that
Yeah,
happens
so I'm going to make you.
if you don't do a trial.
I'm going to
If you
make.
don't do a trial run in the office. For some, I have it on a thumb drive on my app, and then I also have it on a thumb drive, and I have it on my computer that I emailed it to myself. But
Okay.
I'm not sure why is it not opening. Is it the Zoom?
So I just gave you host privileges, so now you should be able to go and share your screen as long as you can
Okay.
open it up on your computer. Then go
I'm
down.
just trying to figure out why it's not opening up on my thumb drive here.
Gotcha. I gotcha.
So I'm having a momentary panic. I hope everybody bears with me here.
No
So
worries, man.
are you able to, I don't know if you're able to commandeer my screen. So I actually have it on my computer.
Okay, so go to the bottom of the Zoom that you open and see the
Now,
little.
and I'm saying it won't open for some reason. I emailed it to myself and have it on a thumb drive.
Gotcha.
So I don't know.
If you want to email to me, I can probably put it up.
Or the other question is it actually on my computer? I'm just not seeing it because I was using two different screens. So is it hanging on? I'm going to email this to you, Ryan, while we talk.
Okay.
You have a Mac over there?
Yeah, I do. Yep.
Okay. So I apologize to everybody.
Are you in the office today? Or are you home?
I'm in the office. We were doing some telemedicine. We're fortunate to be able to do that. And I just stepped off the treadmill trying to get my steps in while doing my telemedicine visit.
Nice, man.
And let's see here. Let me know if you got that.
Yeah,
My other option is I can try the internet in the car, see if that's going to give me a better signal.
I'm pulling it up right now. All right, I got you, man.
Okay, here it is. Actually, now it's finally allowing me to download it here.
Okay.
So I think I'm downloading. So one of us will get it, and then we can start, and I'll make up some time.
Yeah, I have it ready whenever I have it ready, but I prefer if you did it from your computer. That way you can control the slides. So if you can't get it up, just give me the nod, and I'll go ahead and control it for you.
Yeah, Ryan, it says 10 seconds here. So who do we have in the audience today? What's our audience? How many attendees do we have?
Yeah, we have about 60 providers on here. I think typically they're filled with a lot of dentists, a lot of hygienists. There's some GPs on here. We have some myofunctional therapists on here. We have a couple of people from dental practices that are like practice managers. So we got a good kind of mix of, it's a lot of us dental folk.
Good. So it says it's downloaded. And let's see if it opens. Let's see here. I think for some reason my computer thinks I'm still hooked up to my other screen. So it says it's downloaded. File. We'll give it one more trial, and if not, I'm going to go off your screen.
Okay. This is a good example, guys. This is why our physician counterparts, they're never on time. They're never prepared. They just are never organized like we are. So
that's the truth.
I'm just messing with you.
So yeah, it said it downloaded, but I don't know. Can you see my computer, Ryan?
I can't. Did you go to screen share?
Well, I'm just going to go ahead and do this, and pardon my messy box, and maybe you can take control and tell me what's going on here.
Okay. Yep. See if you can pull that up.
There it goes. I'm just not having patience. Are we good there?
Yeah, I can see your screen. Yeah, there you are. You're good. You're on.
Okay.
Yeah, so rock and roll, man. Are you ready?
All right. We ready to rock and roll?
Yeah, man. So go ahead and get through your stuff.
And I'm ready. Is my video or face up?
Yeah,
do I not have my face up?
Your face is not up.
Let me see if I can start video. Okay, there I am. There I am. All right, guys. Thanks for bearing with me in the snafu. Sorry, I don't have the best background. I'm actually in my wife's optometry section of the office. I had my whole cardio set up, but to make it look official. So we're going to talk about cardiovascular assessment and prevention. I'm a non-invasive cardiologist in private practice. I have a master's in public health and health promotion disease prevention. And I like cardiovascular ultrasound and preventive cardiology. I'm affiliated with Christiana Care, even though I'm a solo practitioner. I'm also the medical director of a local Dean Ornish intensive cardiac rehab program. I'm also a managing partner of Ross Indian Fusion Pan Asian restaurant in Lewis, Delaware. These are my disclosures. I'm also looking for more disclosures. Ryan, if you have any for me. We're going to talk about what is cardiovascular disease. And cardiovascular disease runs a gamut of a couple different things. It includes atherosclerosis, plaquing of the arteries, myocardial infarction, heart attack, stroke, congestive heart failure, arrhythmias, and valve disease. But for our purposes, we're going to actually focus on atherosclerosis because we want to talk about preventing a heart attack. But whatever we do to prevent heart attacks will actually prevent strokes. Whatever we tend to do to assess stroke risk or heart failure risk or arrhythmia risk really boils down to trying to stop atherosclerosis. So I like this slide here. A lot of you guys have seen this in school and physio class. How do you get a heart attack? You get a heart attack if you have atherosclerosis or plaque formation. So here you have an artery. I'm going to see if I can annotate. And for some reason, there we go. Let's see if I can annotate. I've lost control of my mouse. I'm going to have to get somebody to grab me my mouse. Anyway, so we have a model here of the artery. The pink stuff is the artery down at the bottom. And you can see the yellow streak where it says a disease initiation and plaque growth. And what that is that's actually where you have LDL, which is the bad cholesterol, transporting cholesterol in the intimal lining. So that first streak you see under disease initiation is actually plaque formation. So plaque forms in the intimal lining of the artery, and then it actually goes over to plaque maturation and vulnerable, which is where the plaque starts pushing through the intimal lining. So there's two ways to have a heart attack, as I call it, as I tell my patients. You can have a heart attack because you have plaque growth, and that plaque keeps growing 40%, 50%, 60%, 70%, 80, 90, and you close off the artery, you starve off blood flow to the myocardium, and you have a heart attack. The other way to have a heart attack is called plaque rupture. So when we were all in college and high school and grade school, we thought that heart attacks happened because you had a lot of intense atherosclerosis and you just closed off a vessel. Slowly the plaque built up. Now we know that there's actually a lot of what we call atherothrombosis. So you have a plaque that's vulnerable, a plaque that has inflammation. And inflammation is definitely well known to our dental colleagues. So you have inflammation in the plaque ruptures. You can see in the graphic there that you actually have some plaque rupture. And with the plaque rupture, the body thinks the artery wall actually has a hole in it. So you have a platelet rave party. So thrombosis in an artery is a platelet rave party where all your coagulation cascade and your platelets come in and you have a heart attack. So two ways to have a heart attack. And this is what we want to talk about preventing. I'm going to try to go on. Give me 30 seconds. I'm going to grab my mouse because this is not working for me. All right. Let's see. Somehow I got stuck in the annotate and it won't let me get out. All right. Okay. So we're going to talk about what are risks for cardiovascular disease. So the risk for cardiovascular disease is age, male sex until age 65. And at age 65, that's when women lose their estrogen and tend to be in menopause, and they'll actually catch up. So estrogen is protective for women. Family history, hypertension, diabetes, hyperlipidemia, tobacco abuse, obesity, and inactivity. So these are the traditional cardiac risk factors. These are things that we learned in school. And as we go through this lecture, we're going to talk about some other things that are risk factors or markers or associated with cardiovascular disease. So basically, these things, age, male, sex, family history, are not modifiable. Hypertension, diabetes, hyperlipidemia, tobacco abuse, obesity, inactivity, those are all modifiable risk factors. So we really want to focus on modifiable risk factors. We want to talk about how do you prevent a heart attack? Well, modify the things that you can control. So number one, you got to know your numbers. So one is hypertension. So the hypertension guidelines have changed. So if you want to prevent a heart attack, you need to get your blood pressure checked and know your numbers. And a lot of my patients will go over Dr. Robinson's office, and he's kind enough to check blood pressure. We have optometrists, ophthalmologists who tend not to worry about blood pressure, check blood pressure. So if somebody's captive in the dental chair, I think it is helpful to check their blood pressure as well as knowing your own. So normal blood pressure these days is 120 millimeters of mercury systolic or less, or 80 millimeters diastolic. So diastolic is your resting blood pressure when the heart's relaxing and filling, and systolic blood pressure is the blood pressure when the heart's squeezing into the artery. So elevated blood pressure these days are 120 to 129 systolic, 130 to 139. We have a lot of patients who will come in and say, my blood pressure is fine. And you ask them what their blood pressure is, and it's 130. Certain populations of people may have a target goal of 130. So despite the new guidelines of saying normal is less than 120, 130 may be acceptable if somebody has carotid stenosis and needs more of a perfusion pressure. If somebody's prone to orthostasis where the blood pressure drops, you may want to run them a little bit higher. If somebody has bad kidney disease, yes, you want to keep the blood pressure low, but you don't want to go too low and drop their perfusion pressure to their kidneys. So there's a little bit of fluctuation, but this is pretty much it. So 120 over 80 or less is good blood pressure. If you're above that, you may want to pay attention. So diabetes mellitus, what is that? That's excessive blood sugar in the body. The most common cause is excessive weight and physical inactivity. And basically you have cells that fail to respond to insulin, or there's a lack of insulin production. That's essentially how you get type 2 diabetes. So know your numbers. Pre-diabetes is a hemoglobin A1C 5.7 to 6.4. Diabetes with an A1C of 6.5 or higher, that's diabetes, a 6.5 A1C. So the A1C is glycosylated hemoglobin, and it basically looks at your hemoglobin and how much sugar you have attached to it. And that gives you your glycemic control or lack of control over 3 months. Another way to do it is a lot of us will get blood sugars checked on a basic metabolic panel when your doctor checks your kidneys. And there you have a fasting blood sugar of 126 or higher on 2 different fasting occasions, means you may be diabetic. So again, know your sugar numbers. Also know your numbers for LDL. So LDL is a type of cholesterol transport protein, and it transports cholesterol to the body. So LDL is known as your bad cholesterol, and it actually serves a good purpose because it transports cholesterol in the body from the liver to other organs. Cholesterol is actually a good thing. It actually makes up cell membranes and hormones. So we need to have cholesterol. But if you have too much LDL transporting cholesterol, they can build up in the arterial wall. So in the first or second slide, I had showed you the artery wall, and the artery wall has an intimal lining. If you have excessive LDL and you have an intimal lining of the artery that's irritated by tobacco, by diabetes, high sugar, by hypertension, by stress, that artery wall is more prone to absorbing LDL. So if you don't have a nice, smooth, healthy endothelium, you're going to get cholesterol deposition where it shouldn't be. Just like in the dental world, if your gums are intact. And that's part of the body's natural defense. If you have good gum health, then you're going to prevent bacteria entry. You're going to prevent inflammation. You're going to prevent endocarditis. So basically, the LDL can harm the intimal lining, and you have to preserve the intimal lining to keep LDL from entering. So LDL causes the buildup of cholesterol in the arterial walls. It forms plaque. It forms vulnerable plaque that has inflammation that ruptures and causes heart attacks. So an LDL less than 70 is optimal. 100 to 129 is near optimal. 130 to 159 is borderline. Most of us would prefer in the cardiology and the prevention world to see your LDL 130 or less, whether that's with medications or that's with therapeutic lifestyle changes. So I wrote down at the bottom, if you have risk factors for cardiovascular disease, you need to be below 130. Body mass index, normal is 18.5 to 24.9. 25 to 29 is overweight. If you're over 30, you're obese. Some of this needs to be taken with a grain of salt. Some people say I have dense bones. I kind of do believe in that. Some people, if they go to a BMI of 24, they'll probably won't feel well. They'll feel a little sickly. So we have to take this with a grain of salt. And also looking at waist circumference is another way of finding out if you're a proper weight. I also have a little asterisk there, and I wrote the fat fit. There is some data that say that obese patients with a BMI of 30 or greater fare better post heart attack. So there might be some protective effect of being a slightly overweight or obese. Also, there's a study a number of years ago that I liked because my BMI is about 27. So I got in, I'm a little bit in the overweight category, but I do subscribe to the fact that if you take two people with the same body frame and one person has a normal BMI and doesn't exercise and eats whatever the hell they want, and you have somebody in the overweight category that does exercise or cardiovascularly fit, they follow a lifestyle program, they don't drink a lot of alcohol, they don't smoke, they could actually be healthier in terms of their arterial age. So their vascular age could actually be lower than their biological age. And I'll show you one of those tests that can prove that. So I take the BMI with a little grain of salt. There's also cardiovascular risk score calculators. And the American College of Cardiology, which is the ACC, has a risk estimator where you plug in some numbers and it gives you your 10-year risk of a cardiovascular event. And the main issue there is with this risk estimator is to give you your 10-year risk for atherosclerotic cardiovascular disease. And depending on whether you're low risk, borderline, intermediate, or high, it's a decision tree for starting a statin versus not a statin. And most cardiologists you go to will say statins are your friends. They're probably healthier than some of the antibiotics that you guys have to give for dental infections and caries and abscesses. Statins get a bad rep, but statins decrease your cholesterol so you don't form cholesterol plaque in the artery and keep building up plaque till you get 100%. And cholesterol not only decreases your cholesterol, but it has an anti-inflammatory effect and actually shrinks some of these vulnerable plaques that have inflammation and are prone to rupturing. So take it from me, statins are your friends. Most cardiologists, even if their cholesterol is normal, will take statins for the anti-inflammatory effect. I don't know if you can see this here, but this is the risk score calculator. It plugs in your age, your sex, your race, and it doesn't have Latinos and it doesn't have Indians like myself in there. So this is for kind of mainstream Americans, but I don't really know who mainstream Americans are. So a lot of this, our melting pot society, this risk score calculator doesn't pertain to a lot of this. Puts in your blood pressure, your total cholesterol, your HDL, your LDL, whether you're diabetic, you're smoker, and it plugs out a 10-year risk. Now, this is the old way of assessing cardiovascular risk, and some of us who are in the preventive world want to do more. A lot of times this risk score calculator, you'll plug in a 40-year-old male and it'll say their risk is minimal, but that may not be the case because their cholesterol may be stickier, and we'll get to that. They may already have atherosclerosis that we don't know about from having bad lifestyle in their teens or their 20s. So if you put somebody through a cardiovascular risk score calculator, they may come out low risk, and but their vascular age may be higher than their biological age, and they warrant a statin. So you have to take this with a grain of salt. So what are additional risk factors? Additional risk factors include periodontal disease. So you guys know this, the dentists have always been ahead of the curve in this. And this was a Korean health study. And they looked at a database of oral health and queried oral health. And there's 14,000 patients out of the 200-some thousand that had a cardiovascular event. And they basically said that frequent toothbrushing and regular professional cleaning were associated with better cardiovascular outcomes, even in those with poor oral conditions. The benefit of toothbrushing, however, was more evidence in the absence of periodontal disease and those with a low number of dental caries. The benefit of toothbrushing showed significant interaction with a number of teeth lost. Similarly, the benefit of professional cleaning was consistent in all oral conditions. So you guys know this. Take care of your oral health, floss. You know, I admittedly was a kind of independent flosser, intermittent flosser, a couple of days a week. And then I went to my dentist, and he yelled at me and basically said, you're studying to be a cardiologist. You should know better. Floss. That's all I'm going to tell you, floss. So definitely flossing is key. It decreases inflammation. There's a lot of people in the preventive world who will say that there's a lot of residual risk out there. So somebody will have a heart attack or stroke. They'll go on goal-directed therapy. They'll go on aspirin. They'll exercise. They'll go on a statin. They'll drop their blood pressure. They'll drop their blood sugar, and they'll still have a cardiovascular event. And there's a term called residual risk. People are still at risk. We've treated everything. Where does this residual risk come from? There are some preventive docs out there who really work hard with their dentists and will really, try to root out periodontal disease. There's a lot of patients out there who don't want the x-ray. They don't want to pay for it. They don't want radiation. They don't want this hard look at periodontal disease and dental caries. But there's a group out there that has the Bale-Donine method. And Bale and Donine are two healthcare providers that will guarantee you, if you come to their office and pay them yearly, that you won't have a heart attack on their watch. If you have a heart attack, they'll give you their money back. And one of the big things that they do is check CRP, which is a marker of inflammation. And they work with a team of dentists who subscribe to the Bale-Donine method. So that's something to think about for our local partnerships here. Again, in terms of periodontal disease and inflammation, poor oral hygiene can provoke bacteremia transiently and inflammation, and that's a mediator of atrial fibrillation and heart failure. So we know if you have inflammation in your body, you can go into congestive heart failure, and you can actually have a risk of atrial fibrillation. I'm sorry here, let me try to move something around. So next, erectile dysfunction. So erectile dysfunction, in my mind, is an adjunctive risk factor. Erectile dysfunction predicts coronary disease. There's this gentleman here, Dr. Graham Jackson, who's passed away from the United Kingdom. He was a cardiologist, and he made the association that when somebody has erectile dysfunction, it often precedes cardiovascular disease by 5 years. So asking men if they have erectile dysfunction is part of our questionnaires here in cardiology. And the thought is that most of erectile dysfunction is an atherosclerotic process that affects the blood vessel. Of course, you can get erectile dysfunction if somebody has prostate surgery. You can get erectile dysfunction from psychological issues, low testosterone. You can get it from other neuroendocrine disorders. So there are other causes. People who have prostate surgery can affect their nerves in that area. But oftentimes erectile dysfunction it is a canary in the mine. It's actually a precursor. So it's something very important to ask. So if anybody says, hey, are you guys using the blue pill, or hey, I have this problem, not just go to the urologist or your primary care doctor to get sildenafil. You may want to send them to a cardiologist, because there's a lot of studies out there that says ED precedes CAD by 5 years. The penile artery is 1 to 2 millimeters in diameter. The coronary arteries are 3 to 4. The next largest arterial bed is your carotid arteries. The next largest arterial bed is your abdominal aorta. Or maybe your iliac arteries going to your legs, and then your abdominal aorta. So atherosclerosis follows a progression. So oftentimes some of the treatment for erectile dysfunction is not just giving them sildenafil and dilating their arteries. It's how do you make their arterial health better? So people look at me kind of weird as a cardiologist when I ask them how their hydraulics are working. Well, if I can get their hydraulics working and help their arterial health in a 1 to 2 millimeter artery, then you pretty much know you can help the coronary arteries at 3 to 4 millimeters and decrease their cardiovascular risk. So we don't want to discount erectile dysfunction by simply sending somebody to the primary care doctor or the urologist for Viagra, because I can tell you they will not look at how to benefit their arterial health. Sleep apnea, don't forget sleep apnea. This is kind of the bastard stepchild in cardiology. We're starting to realize this a lot more. When I was in medical school and internal medicine training, we really discounted obstructive sleep apnea. We just said that obese people got sleep apnea. But when now we know that small people or thin people can get sleep apnea, and you guys are looking at the oropharynx all the time, looking at their Mallampati score. So I really think it's important to direct people who have a small oropharynx or a large tongue over to pain and sleep therapy or your pulmonologist or your sleep doctor of choice, because this is a big problem, right? Obstructive sleep apnea causes resistant hypertension. It causes insulin resistance and diabetes. You get a lot of cortisol release when you're apneic at night, and that cortisol releases blood sugar, and that blood sugar does not help the arterial health. Also, you get erectile dysfunction from obstructive sleep apnea. Well, how do you get that? You have endothelial dysfunction through marked accelerated hypertension at night, and you get microvascular disease. You get a decreased testosterone. Well, from the cardiac standpoint, if you're getting erectile artery, penile artery endothelial dysfunction through hypertension and microvascular disease, you're surely getting it in your coronary arteries. And also when you get apneic and you're gasping for air and you're getting vasoconstriction in your pulmonary arteries, to try to slow the blood down in the lungs and able to slow it down to get more oxygen, right? You get apneic at night because you don't have enough oxygen. Your body's trying to take oxygen in, and as a result of hypoxia, you get vasoconstriction. That vasoconstriction causes hypertension. It also causes pulmonary hypertension. And you want the pulmonary hypertension or pulmonary vasoconstriction to slow the blood down as it goes through the lungs, because the blood wants to hang around and grab the oxygen. It's kind of my layperson's description. And that vasoconstriction causes vasoconstriction in the coronary arteries. That's why people die of arrhythmias. So if you remember Reggie White, who was a minister of defense for the Eagles, for some of you guys who are my age or a little bit older, Reggie White left the Eagles and went over to Green Bay, and he died from a complication of sleep apnea and non-sustained ventricular tachycardia. So when we do sleep studies, or you guys do sleep studies, you might see bouts of tachycardia where the heart rate bounces between 48 beats a minute and 100 beats a minute. And you got to make sure that that's not ventricular tachycardia. So obstructive sleep apnea can promote coronary disease and cause malignant arrhythmias and death. So how do you prevent coronary disease? Well, you screen yourself for sleep apnea if you have risk factors, or and screen your patients. I bring this out here, South Asian descent, just to remind me of an article I wrote, atherosclerosis in the Indian population. Those people who are in South Asian descent, myself included, are a high risk of coronary disease. When this concept came out, people were like, how can you condemn an entire race of people? The gentleman who kind of talked about atherosclerosis in the Indian population was Indian himself, and they accused him of selling out his ethnicity. And I put this on here because myself and my friend Dr. Reddy are both South Asians, and we're talking about atherosclerosis in the Indian population. So it's a topic that's near and dear to both of us because we're both at risk. And we wrote an editorial in Lipid Spin, which is a National Lipid Association's editorial. If anybody wants a copy, I can always send a copy, but I'll give you a little summary. Those people who are South Asian descent tend to be vegetarian, but they tend to be contaminated vegetarianism. Being vegetarian or being plant-based is great, but you can be a contaminated vegetarian by eating pizza and refried beans or eating a lot of oil, as some Indians do. So keep in mind that when you have patients of South Asian descent, that they could be at a very high risk. An interesting statistic is that Indian vegetarians and non-vegetarians have the same LDL rates and CAD rates, in contrast to Western vegetarians who have lower disease rates and lower LDLs as their meat-eating counterparts. So despite being vegetarian, Indian vegetarians have the same coronary disease rates, the same LDL rates as Western vegetarians. So there's something else going on there. And what's going on there is that there's a more malignant and more atherogenic LDL, and you have people who get risk factors for coronary disease like diabetes and hyperlipidemia and hypertension at a lower body weight and a younger age. So interestingly, when Indians come to the United States, they suffer from a higher prevalence of hypertension, diabetes, obesity, and dyslipidemia at a younger age than their Indian counterparts. And there's a higher prevalence of coronary artery disease in Indians despite having normal cholesterol. So the cholesterol profile itself doesn't tell the whole story, and that goes for the Caucasian population too. And we'll talk about that having a normal cholesterol, if you're of South Asian descent or you're somebody with a family history of coronary disease, doesn't tell the whole story. And we'll get into what an advanced lipid profile is, and that's very important. Stress, we can't undermine stress. Stress is a risk factor for coronary disease. There's a study called the Inner Heart Study, which is very telling on stress. And it demonstrated that those who experienced their first MI had basically greater work stress, stress at home, permanent stress in comparison to age and sex mass cohorts. And that was controlled for demographics and medical factors. And this was across multiple countries. So stress does kill. This is a great slide here from the Journal of American College of Cardiology, where acute stress actually causes sympathetic nervous system stimulation. And we know the sympathetic nervous system is great for fight or flight, but if you're in fight or flight all the time, that's bad. So the sympathetic nervous system can increase your heart rate, increase blood pressure, vasoconstriction, and cause myocardial ischemia. It can cause heart arrhythmias. It can cause endothelial dysfunction, making your endothelial lining of your blood vessel less smooth, like a piece of granite, and more sticky like Velcro. Thus, your LDL can stick more. If LDL sticks more, you're going to have more plaque. You're going to have more vulnerable plaque. Stress can actually activate platelets and make you procoagulant or prothrombotic, and make you clot your artery. So I think going back to Dr. Robinson and Lauren's, lecture about 2 weeks ago, talking about breathing. We'll get to more of that. Really helps counteract the sympathetic nervous system. Let me see here. So what are adjunctive tests for risk assessment? Adjunctive tests for cardiovascular risk assessment include advanced cholesterol profile. We're talking that people who can have a normal cholesterol profile, be of South Asian descent, have a strong family history, and still have cardiovascular events. So a normal cholesterol profile doesn't tell you everything. So an at-risk population, if you have a normal cholesterol profile, and you have a strong family history of early coronary disease, so strong family history of early coronary disease, you're South Asian, you have diabetes, you have hypertension, I want to see an advanced cholesterol profile. Approximately 50% of patients with heart attacks or stroke have normal cholesterol levels. Why is that? Maybe they were unhealthy at a younger age and they had bad cholesterol, high cholesterol, they deposited plaque. And now as they get older, their plaque is rupturing. Maybe they have more atherogenic LDL and sticky particles. So you can have, each one of us could have 100 LDL per deciliter of blood. And I could have LDL that has stickier particles of cholesterol that make up my LDL, and you could have 100 LDL per deciliter of blood and just have a normal amount of particles in your LDL. So your LDL is bad, but my LDL is more bad. There's something called lipoprotein A, which is a sticky particle that sticks to LDL and makes LDL more atherogenic. So you want to know how much LDL you have, and you want to know what comprises that LDL. Is your LDL stickier? So in patients with cardiovascular risk factors and patients with family history, patients with certain ethnicities, you want to subfractionate your LDL. And advanced cholesterol profiles don't just calculate LDL based on a calculation. They actually use NMR spectroscopy and spin down the blood and look at your LDL and what makes it up. You also want to look at HDL size And is your HDL protective? Some people say, well, I have an HDL of 70, but not all HDL is protective. We know that some people with high HDL have HDL sizes that render them not protective. So we have people with HDLs of 80 or 90, and you want to have it above 40 if you can, but some people with 80, 90 to 100 are still having heart attacks. And also want to point out that elevated triglycerides kind of point to the fact that you might have some other atherogenic particles there. So people will have normal cholesterol profile, normal LDL, normal total cholesterol, and basically their triglyceride numbers will be high. That's a giveaway. Other things to look at here are inflammatory markers. We talked about inflammation, HSCRP. It will tell you that there's inflammation in your plaque, maybe growing. Myeloperoxidase, LP-PLA2, those are markers that show that plaque is vulnerable to rupture. The myeloperoxidase and LP-PLA2 are byproducts of white blood cells eating oxidized LDL when they deposit in the intimal lining. So if you have a normal cholesterol panel, normal LDL, but you have inflammatory markers, that's bad. You may have plaque that you don't know about that could rupture. So getting advanced cholesterol profiles are a must. Another test is coronary artery calcium score. A coronary artery calcium score looks at calcium that's in your coronary artery lumen, or actually in the intimal lining, waiting to push through and make an obstructive plaque. So on the left-hand side, you have a heart. It's a cross-section looking through a CAT scan as if we cut off somebody's torso and we're looking from their feet up to their head. There's the heart there. I'm not going to try to annotate because every time I annotate, my slide set gets stuck. But on the right-hand side, all that white stuff is actually atherosclerosis. On the bottom right at 6 o'clock, there's a nice round gray area, and it's surrounded by white like PVC pipe. That's the descending thoracic aorta with atherosclerosis in it. I know Dr. Robinson has a CAT scan to look at oral airway, and a couple of times he's called me, hey man, your patient has carotid atherosclerosis. So something to pay attention to. If the more calcium you have, the more echo-dense areas there are, that means you have more atherosclerosis. If your coronary calcium score is high, you have more risk of having a heart attack. So this is done for $150. Delaware Diagnostic Imaging, my friends on Limestone Road, will do this for anybody, $150. Get your primary care doctor to write it, and you can tell if your coronary risk is high or not. So this tells you if you already have made plaque. Adjunctive test for risk assessment is carotid intimal medial thickness. On the bottom here, where you have this vertical green line and the red line is actually outlining Dr. Robinson's carotid artery, his left carotid artery. This is a carotid intimal medial thickness test. And what we are looking for is we're swiping the carotid artery and we are looking to see if he has any intimal thickening or subintimal atherosclerosis. So if you look right above the red line and follow it over to the left of the vertical green line, there's a little bit of a white stripe there. That little hazy stripe is a little bit of intimal thickness, but he does not have any atherosclerotic plaque. And this is a window into your body. This little triangular structure that has the angled green marking in it is your left jugular vein, left internal jugular vein. So the carotid intimal medial thickness test will tell you your biological age versus your vascular age. It tells you your biological age versus your vascular age because it looks at tables and it looks at down to the micrometer of what your intimal thickness is. If you swipe the carotid artery and you see a big atherosclerotic plaque, which this doesn't have, you're high risk for cardiovascular disease. Otherwise, we measure the intimal lining and we can tend to see if somebody has pre-plaque. And if you have a little bit of intimal plaque, as Dr. Robinson has here, the idea is go do exercise and enhance your diet. But this little stripe and this intimal deposition is pre-plaque. It can go away. It will not rupture. So this is something that a lot of cardiologists don't do. Some of the vascular surgeons do. This is a great test to get. I throw this out here because every time I think of carotid intermedial thickness, I think of Dr. Joel Kahn, who wrote this great book called Dead Execs Don't Get Bonuses. And it's so true. And this is the ultimate guide to surviving your career with a healthy heart. And Dr. Kahn talks about carotid intermedial thickness testing, and he talks about coronary artery calcium score and why you should get them and how to keep yourself healthy. So it's a very easy read and quick read. I encourage you guys to buy this book and maybe share it. Another test is ankle brachial index, and testing where you take the brachial artery flow versus the lower extremity artery flow, and you do a ratio. And if it's a closed system, so the blood pressure in the brachial artery and the lower extremity artery should be the same. If your ratio is off, that means you probably have some peripheral arterial disease. We don't know why, but atherosclerosis has a predisposition for the lower extremities, but not the arms. So if you have, what this is looking for is to tell if you have low in your lower extremities, because peripheral arterial disease is silent, whereas coronary blockages will result in shortness of breath or chest pain when you have an early warning to go in and get help. By the time you have leg claudication, you're already killing tissue in your leg. So the ankle brachial index test is a great test to get, especially in people who are 50 and diabetic or 50 and have ever smoked. Traditional cardiovascular testing, there's an EKG that we do in our office to look for coronary disease. This is a screening tool, but it can be non-diagnostic even when you're having ischemia. So you have to take the ECG with a grain of salt. Having a normal EKG does not mean that you don't have atherosclerosis already. This is an echocardiogram. I was trying to get it to play. My wife told me I should have animation. This is Dr. Robinson's heart, beautiful looking heart here. And the reason an echocardiogram is a great tool, the echocardiogram can tell you if there's any stressors in the heart. This is the mitral valve, left atrium, mitral valve, left ventricle, left ventricular muscle here. Great squeeze, thin muscle, not thickened. And this is the aortic valve, nice and thin. So an echocardiogram is great because if you have a thickened mitral valve, that means maybe you have some hypertension or atherosclerosis. If you have a thickened aortic valve, you may have hypertension, atherosclerosis. If you have a dilated left ventricular chamber, you may be having obstructive sleep apnea. If you have a thickened left ventricle here, that could be accelerated hypertension that you're having. Just like dentists will look at the gum, you can tell if we've been grinding. You can tell if I'm biting my cheek. You can tell if you're not flossing. You can tell, look at the oropharynx and see if there's gastroesophageal reflux disease. So you can see different strains on the oropharynx and the gums. I can see different strains on the heart. So I love the echocardiogram test because, again, you can see inside the body just like you can the carotid intermedial thickness. Stress testing. Everybody wants a stress test when they come to the cardiologist's office. Best performed for symptoms or known atherosclerosis and not in routine testing. There's a lot of primary care doctors out there, a lot of doctors out there who do stress testing yearly. Patient has no symptoms, no risk factors, or 65, and they get stress testing yearly. A stress test only detects 50 to 60% stenosis. If you don't hear anything about stress testing, please know a stress test only detects 50 to 60% blockage. I can't tell if you have a 10% blockage, a 20% blockage. And often what happens is larger stenoses, 50% or more, a 70% blockage has been there for a while. It's often calcified. It often may not grow anymore if you have good therapeutic lifestyle changes and good health at the current age. Maybe when you're younger, you were partying, you were smoking, you were drinking, you made a 70% stenosis. A 70% stenosis or blockage can be stable. I worry about the 10% plaque, the 20% plaque that's new, that's soft, that can rupture. So again, a stress test does not pick up smaller, more vulnerable plaque. A negative stress test does not mean you're in the clear. It does not tell me if you have small plaque. So often I'll follow a stress test, which I've done for somebody who has a new symptom of chest pain or shortness of breath. And if they have some coronary risk factors, I'll follow that up with a coronary calcium score to see if they have plaque, to see if I need to ramp up their risk factors. So something to think about. So stress tests can be treadmill, which is exercise, or it can be pharmacologic. We prefer a treadmill stress test because it's more physiologic and you're walking. A pharmacologic stress test is used for people who can't walk or people whose EKGs we can't easily assess. And then there's also imaging. When you do a stress test, you want to image. You can image the heart with an EKG, nuclear camera, taking nuclear pictures and x-rays of the heart, or ultrasound. These are my last set of slides. I'm gonna try to blow through this here. Everyone keeps asking me about COVID-19. What do you do for COVID-19 and protecting your heart? And I'm also gonna cover how do you protect your heart with COVID-19. The same things that you would do to protect your heart before COVID-19 for good cardiovascular health is the same thing that you should do to protect your heart from COVID-19. I throw this slide set here, and in the slide set at the bottom right, the American College of Cardiology has devoted much information to educating cardiologists about COVID effects of the heart. We're still learning about how COVID has affected the heart. You know, back in March, I was watching webinars with the cardiologists in China to try to be on the forefront and find out how COVID affects the heart. And one thing we know is that COVID can cause myocardial inflammation. It can cause chest pain. It can cause cardiomyopathy, which is a weakened heart. It can cause congestive heart failure. It can cause inflammation, right? There's a huge inflammatory response. Thus, it can rupture plaque, and it can cause heart attacks. It can mimic heart attacks as well. So we'll go on. So COVID-19, what can we do to decrease the risk to our heart? Number one, wear your mask. There's asymptomatic spread. Wear your goggles. We know the flu virus. My wife, who's an optometrist, has told me that virus can get into the eyes, go down the nasolacrimal gland, into the nose and the oropharynx. And you guys know the anatomy there. So wear your eye protection, wear your mask. I mean, we were wearing masks back March 10th and people thought we were crazy walking around with masks, but now we know that there's asymptomatic spread. So first and foremost, how do you protect your health from COVID-19? Protect yourself. Also think about doing a PCR, oropharyngeal swab, and antibody testing for our employees and, you know, and healthcare providers in our community. So Dr. Robinson and I have been talking offline about should we figure out how to get PCR swabs into healthcare providers? Should we get antibody testing in for our fellow cardiologists, primary care doctors, and our fellow dentists? And you know, are we going to anger the public health department? Are we going to anger the government? You know, right now I think it's every man and woman for themselves. So again, the same thing you would normally do to decrease your risk of atherosclerosis and heart attack is the same thing you got to do to protect your heart from COVID. So each one of these slides is for COVID and non-COVID times. The impact of healthy lifestyle on life expectancy in the U.S. population. So adopt 5 healthy habits and you live 12 to 14 years longer. So 2 large databases looked at 123,000 men and women, and they had 42,000 deaths. This is a 34-year-old database by circulation. And they found that 5 behaviors: healthy diet, not smoking, getting regular physical activity, moderate alcohol consumption, and maintaining a normal weight could add years to your life. So on average, a 50-year-old male who adopted all of these would live 12 years longer than a male who did none of these. A woman with the same 5 habits would live an average of 14 more years in a woman than with none of these habits. So eating a healthy diet, just tweaking your diet a little bit. Don't smoke, stop smoking, get some physical activity, moderate alcohol consumption or none, maintaining a normal weight can all help. The PURE study found that, I keep having, I'm sorry, my picture and your pictures keep coming in my way, and my mouse is not sensitive enough to get rid of them. The PURE study found that in just 30 minutes of physical activity 5 days a week could prevent 1 in 12 deaths and 1 in 20 cases of cardiovascular disease worldwide. The PURE study found that physical activity incorporated into daily life had the same benefit as leisure activities, you know, going to play golf, doing your gardening, all that stuff can help. The stability trial showed that walking at a brisk pace for as little as 10 minutes a day, even during your lunch break, or a slower pace for 15, 20 minutes a day, again during your lunch break, can reduce all-cause mortality by 33% in patients with coronary disease. A little bit of walking. You know, I've been doing my telehealth on a tread desk and trying to walk 5-6 miles a day. I mean, I feel great doing it. So, you know, I think as a community of healthcare providers, we really need to set an example, give our staff 10 minutes to walk during lunch break, Dr. Robinson and I are trying to enroll a Walk with a Doc for all of us here. I'm a member of a Walk with a Doc chapter where we encourage patients and employees to walk with the healthcare provider. We give a 5-minute lecture. We do blood pressure screening. So stay tuned for that. But you guys got to walk. Let me see here. Here's a great slide. The scientific 7-minute workout put in the New York Times. And this is 7 minutes. And basically you do a minute of each one of these exercises and you rest for 10 seconds in between. And over 7 minutes, you're doing a lot of resistance training. You're increasing your heart rate. You're helping your lung function. And you're advancing your cardiorespiratory system. So we're encouraging people during COVID to do this 7-minute workout if they can't get out. We've used the same PDF for all my heart patients in the office when they give us an excuse that they don't have time. Of interest during COVID, we're getting a lot of complaints of shortness of breath and fatigue, and it's not coming from COVID infections. It's coming from the fact that people are being sedentary. So we're really encouraging people to do this 7-minute workout at home. One, to decrease your cardiovascular risk, decrease your blood pressure, decrease your heart rate, decrease your stress, increase your VO2 max. And all those things, can help your immune system and help you fight COVID. Other things here, trending controversies in cardiovascular nutrition. I think I got about 5 slides left here. I put this up here because the Journal of the American College of Cardiology put an article out a couple years ago, trending cardiovascular nutrition controversies, because there's a huge controversy with nutrition. Do we go Mediterranean? Do we go plant-based? Atkins, paleo, what works? Traditionally, cardiology has been a fan of the Mediterranean diet, because it allows some lean meats and it has a lot of grains and fruits and vegetables, has a little bit of alcohol in moderation. And now cardiology likes plant-based diets. But the common factor with all these diets, I think, whether it's Atkins, why do people going to Atkins do okay for a little bit, or paleo or keto? The common factor is these diets decrease sugars. So I think the take-home point is, if you want, I think for cardiovascular health, Mediterranean diet if you want to eat meat, plant-based diet if you want to feel a little bit better, but the common denominator is decreased sugars. In this same article, they talked about summary of a heart harmful and heart healthy food and diets. So extra virgin olive oil is a better type of oil. Eggs have evidence of harm, and you want to limit them to maybe once or twice a week. Blueberries, strawberries. So the American College of Cardiology is advocating a lot of antioxidants, nuts, green leafy vegetables, plant-based proteins are all the way to go, and decreasing your saturated fats, processed meats, processed sugars. So this is a good slide for you guys to go back and look at. And in terms of plant-based diet, I always think of my buddy, Dr. Khan, who came up with this book, Vegan Sex, Vegans Do It Better. And the reason he wrote this book is he felt that a plant-based diet was really helping coronary blood flow, penile blood flow, and in his teaching of plant-based diets, he was actually finding that erectile dysfunction actually got better because you're improving endothelial health. Just like if you give statins to somebody with erectile dysfunction, their erections can get better because you're improving the endothelium. So we know that plant-based diets can actually decrease heart attacks, decrease heart disease risk. There's a great interview with President Bill Clinton and Sanjay Gupta, CNN, called The Last Heart Attack, where they really talk about plant-based diets for reversing heart disease. So the same thing with erectile dysfunction. So I just throw this out that plant-based diets can help all arterial beds. Talking about dietary patterns, one thing to keep in mind with COVID, and being in the pandemic and being quarantined, people's dietary patterns tend to change with changes in environment for better or for worse. So it's not just COVID. When my patients travel to Florida, they go back home to India, they go to California, they go to a different environment, they eat different foods. When they eat different foods, their blood pressure goes up, their blood sugar goes up. That hurts arterial health. And there's also changes due to access. Now that people are buying Instacart and getting groceries from home, I know in our house, we're trying to get the spaghetti sauce since we don't make sauces in the winter with low sodium, and the Instacart person who's putting it in our cart says they can't find it. So now all of a sudden our spaghetti sauce has 400, 500, 600 milligrams of sodium per serving, where we used to get it lower. So I'm at risk of my blood pressure going up. changes in brands. People might get one loaf of bread with less salt or fat, and now they get another one because it's being delivered to them. So we're seeing a lot of marked blood pressure increases in the time of quarantine. So don't change your dietary patterns, whether it's quarantine or travel. We also know a lot of people's blood pressures are plummeting because they're not going out to eat, they're cooking healthy meals. So, we don't want you to drop your blood pressure because you're eating really healthy and get lightheaded, dizzy, and have syncope and pass out and hit your head and go to the OR during COVID times. So monitoring your blood pressure, monitoring your intake. There's a great article in the New England Journal of Medicine in 2008 about the World Cup, and I think it's relevant to heart health in COVID times. So during the World Cup in 2006, there was an increase in chest pain admissions to the ER of German citizens during World Cup. And they felt that all the German men were sitting at home watching World Cup matches, going to World Cup matches, not taking their medicines, eating fried foods, eating fatty foods, drinking more alcohol, forgetting their medicines, not exercising. There was more heart attacks. So we have to watch that out in COVID. I try to counsel my patients, you still have to take care of your heart health. Do the same thing that we advocate pre-COVID. Drugs for cardiovascular health. People who have risk factors, people who have atherosclerosis should take aspirin. It's been a little controversial. Should we give a 40, 50-year-old who has no risk factors, no atherosclerosis or plaque, an aspirin? No, you don't give them an aspirin. But if they have significant risk factors on the risk score calculator or they have atherosclerosis, they should stay in an aspirin. The same thing during COVID times. Keep taking your aspirin, because if you have vulnerable plaque and you get COVID, you could have inflammation and promote plaque. The aspirin will decrease inflammation, decrease the rupture of vulnerable plaque. Also, for an at-risk population that's sedentary, an aspirin may not be bad because COVID promotes clots, lung clots and blood clots in the legs. Statin drugs are great, as I mentioned before. Keep taking your statin. I think everybody should be on a statin as long as you monitor for side effects. Statins actually decrease inflammation in the coronary arteries. As I told you before, inflammation can promote plaque rupture. Nitric oxide, a lot of stuff about nitric oxide with COVID. Nitric oxide, sometimes I like that for resistant hypertension, whether it's a supplement or nitric oxide rich foods, because nitric oxide provides vasodilation. There's some data that says that maybe nitric oxide high levels could prevent against COVID because it enhances the oxygenation in the lungs. Also, it may dilate coronary vasculature as well. And Dr. Robinson had mentioned Buteyko breathing, both Patrick McEwen. I highly recommend that you guys go back and learn that breathing technique, because there's a lot of nasal nitric oxide that can be activated that could help lung health. And if lung health has helped, cardiovascular health has helped as well. Hypertension meds. You got to take your blood pressure meds to take the strain off your heart. And you got to continue it during COVID-19. Can't forget to monitor your blood pressures. Can't forget to take your blood pressure medicines. ACE inhibitors, angiotensin receptor blockers, a class of medications. There was some press that they may enhance the uptake of the COVID-19 virus in the lungs. The Chinese cardiologists who are kind of on the forefront of studying this has said that that is not the case. The American College of Cardiology, the American Heart Failure Association all said that continue these medications. Some of our patients are trying to stop lisinopril, captopril, ramipril, Diovan, valsartan, which are ACE and ARB class of drugs, because they heard it might give them COVID. They're actually cardioprotective. They'll keep you from having heart failure, so continue these meds. Diabetic meds are heart protective. We know that if you take your diabetic meds and you drop your blood sugar, or you treat prediabetes and drop your blood sugar, that you can actually improve cardiovascular health. A drug by AstraZeneca, Farxiga, just got an indication to prevent heart failure decompensation, even in non-diabetics, and that's a diabetic drug. Sleep, so last couple of slides, sleep duration linked to cardiovascular disease. So make sure you get enough sleep during COVID times. We know sleep boosts the immune system, as we heard from Dr. Robinson. Interestingly, we're getting a lot of complaints of bad dreams, and a lot of people are blaming my cardiovascular medicines during this pandemic as causing bad dreams. But we know that if you alter your sleep-wake cycle and you're doing a lot of REM sleep and not deep sleep, correct me if I'm wrong, Ryan, that you may remember your dreams more. So people are remembering their dreams and they're vivid, and they're blaming the meds. So get sleep so you don't blame my meds. Again, going back to breathing, promotes nitric oxide, decreases stress, decreases pain, decreases blood pressure, increases VO2 max, and it actually helps treat depression. And remember that depression can manifest as chest pain. So during COVID-19 times, we want people to do their breathing to help their stress levels so they don't get stress-related chest pain and have to go to the ER unnecessarily. We want them to quiet their depression down. We want them to increase their nitric oxide to help their cardiovascular health and help their VO2 max. So one thing to remember is breathe. Breathing helps your cardiovascular health. You can see on the right-hand side that if you teach meditation and breathing to heart failure patients, this table is for heart failure patients, you can actually increase their 6-minute walk test or their stamina. You can teach heart failure patients meditation. You can actually help with their depression. So breathing is phenomenal. I mean, you can't not breathe and focus on breathing. Again, I tell you to look at the Buteyko breathing by Patrick McEwen. I thought it was a great breathing, and Dr. Robinson and Lauren had given a demonstration a couple of weeks ago, and it's recorded on Zoom, so please look at that. Last couple of slides here, proper ergonomics. Why do I preach this? Because for good cardiovascular health, you need to stand. Sitting is the new screen time. We're all doing telehealth, and we're all sitting at computers, and that's decreasing our life. It's increasing our cholesterol, increasing our blood sugars. So standing is good. Our bodies are meant to stand. During this COVID pandemic, I've probably been standing 8 or 9 hours a day on my tread desk or in my office. I only sit for 10 minutes, and so far I haven't gotten any leg edema. I think adaptively, our bodies are meant to be upright. So stay upright, because there's a lot of studies out there that's saying that standing and tread desks help your posture, decrease musculoskeletal pain, and they actually make your metabolics look better. Also, avoid prolonged sitting because it can result in leg edema and blood clots. Change positions frequently when working from home. We're seeing a lot of complaints of neck pain, arm pain, chest pain, of people who are scared that they have coronary disease or they're having a heart attack, in heart attack patients, and it's because they're sitting, they're hunching over, they're not paying attention to ergonomics. So in the COVID pandemic, we don't really want to flood the hospitals, so avoid having neck pain, arm pain, and chest pain by paying attention to your ergonomics. I'm getting a lot of headaches. A lot of people are blaming my cardiovascular medicine for having headaches. We check their blood pressure is okay. I think it's from a lot of screen time. So my wife, who's an optometrist, always says, if you're using a screen every 20 minutes, look away for 20 feet for 20 seconds to decrease the strain on your eyes. Last slide or two, cardiovascular disease does not halt for COVID-19. We know cardiovascular disease continues, but we're having a lot of literature that says, where have all the heart attacks gone? Christiana Hospital has a decreased admission for heart attacks and strokes. I know my uncle's a cardiologist in Chicago. They have the same decreased numbers. It may be that people are not exerting themselves in their lawn. They're not going out doing dumb stuff. Maybe they're not drinking or eating as many wings or at the bar and giving their heart a fatty load and causing plaque rupture. Maybe they're also ignoring their symptoms. We're hearing some sad cases of people waiting too long. Their myocardium and their heart is beyond repair. People are dying at home because they're not paying attention to their heart symptoms, and they're also not paying attention to heart health. We haven't seen reports of large number of patients getting COVID-19 by flooding the ER. We don't want people to go to the ER because we don't want them to take away valuable resources, but for unnecessary things. But if you're having necessary issue, you got to pay attention to your heart health. So the American College of Cardiology has put this graphic out that says, don't ignore heart symptoms. So we want to remind our patients of that. I'm going to finish. I'm done here. I'm sorry I went over. I really appreciate people staying on. I know it seems like we did not lose a lot of people. One thing I want to say real quick in closing is that two things. We all have to do what we do best to the best of our ability in order to pull out of this pandemic. And you guys are all healthcare providers. And one thing I like about dentists, when I go to my dentist, Dr. Kaz, I haven't switched over to Dr. Robinson yet, but Dr. Kaz always asks me, how am I doing? How's the practice going? Am I taking care of myself? Am I going to the beach? And that means a lot to me as a client, because I'm a captive audience in his chair when he has his hands on my mouth. And as healthcare providers and as somebody who's trained in public health, people, whether you're a dentist, you're a hygienist, you're a hairdresser, you're a barber, I mean, the people in those professions have people come every 6 months, and you have a captive audience who can't move, maybe can't talk. I mean, your profession lends itself to helping with cardiovascular care and prevention of cardiovascular disease. So asking patients these questions, and I know working with Dr. Robinson, he's done a lot of this. And I know Dr. Kaz, if he's out there listening, I appreciate him asking me those things. I know a lot of people in the dental world are doing this, but to make a difference in cardiovascular disease, I need you guys who are seeing patients more frequently than I am. And you're seeing patients that don't come to me. So I really encourage you guys to ask these questions. Oh, you have a history of hypertension, you have a history of diabetes. Even if you don't have a blood pressure cuff in your office, at least asking your patients, are they checking their health and checking their numbers? So I appreciate you guys listening, and sorry I went over, and I apologize for the lack of technical knowledge here.
No, so thank you so much, Dr. Hasmani. That was fantastic. I wrote down a ton of notes. I've learned so much from you over the last couple of years, and I appreciate you throwing my heart up there for everybody to see. And
Looks good.
I'm glad that I could be a model patient for you. And I've been sticking to that plant-based exercise diet that you gave me, the prescription that you gave me that didn't include any medications, just included some lifestyle changes.
Exactly.
So I truly appreciate everything that you've done for me and my family, and of course my my loved ones, my friends, family, and all that stuff. So a couple questions real quick. So Jonathan wants to know, what are some great tips to reduce your LDLs?
I think number one, first and foremost, is fire your parents. You know, so sometimes you can't do a lot about your LDL because your genetics really determine it. So there's some people who do everything that we tell them to do. And I know, and that includes what Dr. Robinson's saying about the breathing, and Karen Smith has talked about plant-based diets, but sometimes you can't shake your genetics. So I think number one for LDL, however, is exercise, 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 aerobic exercise. And a lot of my patients say, I ask them if they exercise, they say, no, I don't exercise. And then 10 minutes later, you find out they walk 30 minutes a day, or they take a stroll during work. So number one is walking. We see tremendous drops in exercise with walking and with running. So I'm not advocating that you run, but if you like to jog and you run, just keep in mind that with running, there's a J curve. So as you run, your cardiovascular benefit, your cardiovascular mortality and morbidity drop. And then as you get to extreme running, triathlons and marathons, they may start going up. But number one, exercise, aerobic exercise, whatever you choose, row machine, erg, bike, walking, walking the dog. And then number two, diet. We're seeing a huge drop in LDLs, and I talked about LDLs having atherogenic particles, a huge drop in atherogenic particles with the plant-based diet. There's a lot of integrative and functional medicine doctors out there who hate statins, and I'll get in fisticuffs with them because I think statins are the answer. Statins are great because they have many benefits, but a plant-based diet, and I've starting to become a believer and gotten more into plant-based, and I've sent a lot of patients over to Karen Smith, who's given a lecture recently. I think experimenting with a plant-based diet, I don't advocate people going vegan. So in an interest of full disclosure, I grew up in Sussex County. I love my seafood. I eat fish and chicken. I try to limit myself 5 to 6 times a month. If I go 7 or 8, I'm not going to feel bad about it. Sometimes I go 3 if I can, but I'm not going to feel guilty about it. I'm going to enjoy that fish. I'm going to enjoy that chicken. I had crab cakes from Tyler's last night trying to support my local restaurants. But what I'm saying is shade towards plant-based, increase the fruits and vegetables, decrease the bread, decrease the size of the chicken breast, and eat a little bit more vegetables. I've been amazed. My LDL dropped from 70 to 54 by deciding that I'm going to eat fish or chicken 5 to 6 times a month. So the plant-based doctors have really shown me that's one. And then I think number 2, don't hesitate to take a statin. I think those are the two, and then decreasing your saturated fats. So we know that eggs are good because they have some omega-3 fatty acids. So I think eating leaner meats, not eating eggs every day, getting into a little bit of oatmeal, maybe eggs 3 days a week. And those are the things that we're really subscribing to.
Yeah, that's fantastic. So a couple little comments of praise. You guys should move to Lewis full time. We need good doctors down here, and I think
we're trying. If Dr. Robinson gives me another disclosure, I'll be down there.
So she said your restaurant is a great restaurant, and wish it was open. Are you guys not open?
We are open for delivery. Tell her thank you. We're open for delivery. Call the main number. And just as an aside, if anybody's interested in a heart-healthy diet, if you call, Chef Gigi will answer the phone, and he will give you a heart-healthy diet per your needs. He was cooked somebody 20 different vegan meals to go and froze it for them the other day. So Ross does have heart-healthy food.
Yeah, I've personally been to Ross, and I have a house in Lewis, and it is top notch down there. So we're looking forward to getting back down there and enjoying some good cuisine. So if anybody's in that area, make sure you stop by and drop Dr. Hasbani's name. You might get a drink on the house or something. And then we have somebody out of UK, a UK-based hygienist and buteyko-therapist, and she said, "Thank you so much. It was very interesting." So again, I think we need to end here because my assistants are yelling at me. I have an emergency downstairs that I need to treat. Yeah, thank you so much for everything that you've provided on here. I think everybody got hopefully some good pearls to take back, and I think again we're moving more towards the paradigm where we all communicate properly. We look at the patients more whole health centered, and when we're all on the same team, our patients will benefit, and so will we. So again, I appreciate everything today, and I'm sure I'll be texting with you in a little bit.
Yeah, thanks, Ryan. And if anybody has any questions, please have your team forwarded that. I neglected to put my email address on there.
Yep, will do. I will. I'll be able to send that out. And yeah, we'll see you guys all on Thursday for a lecture on exercise in order to relieve stress by Dr. Doug Adams, physical therapist. So we'll see everybody next time, and everybody have a good day. Take care.
Yep, thanks a lot.